Hi, good day. We're going to go through some cases that how point of care ultrasound can assist us in day-to-day practice, especially in an intensive care unit. So this is where I come from. I come from Sarawak, okay, and this is Nepal. And Sarawak is a place full of a lot of beautiful culture. And when you did point of care ultrasound, seeing is always believing. Okay, so this is a collapsed uh, lung, yeah, that look like a fish in the large pleural effusion. And also sometimes you need to do some imaginations. Okay, so this is like a fried fish, similarly in the massive pleural effusion. And seeing is believing. So a lot of time we need to see in the eager eye. So if you have some imagination, so it look like an eager eye. All in all, when you do point of care ultrasound, we're not trying to make you all to become a radiologist, but to rather assist us in the clinical practice or in the situation, difficult situation, or in the procedures. So point of care ultrasound is just to answer, helping us to answer specific clinical question in real time. It's a supporting tool on top of the clinical judgment and help us in terms of doing procedures. So let's go to case number one. Case number one, the child have severe facial injury. We have limited view during intubation. Despite intubations that you thought are successful, but they have the child has very poor chest expansion. Now your question is that, is your endotracheal tube really in place in this situation? So this is how point of care ultrasound can assist us. So this is a normal ultrasound of the vocal cord. You could see that this is a thyroid cartilage, okay, and then two vocal cords are moving very nicely. In a situation whereby to determine whether endotracheal tube is in place or not. So at the level of vocal cord, sometimes when you look at the vocal cord, and you could see if there's a tubular structure inside this vocal cord level, so you could quite assure that the endotracheal tube is in place. So beside that, sometimes the longitudinal view will help. So this is a longitudinal scanning. You could see that this is a cricoid cartilage, thyroid cartilage. This is a trachea ring. Okay, this is a normal longitudinal airway, right? So these are the corresponding level that we've gone through. So sometimes it can tell us the assist us to see whether the tube is in or not. So this is a normal patient without tube. So this is a patient with the endotracheal tube, then you can actually see the tips. At times, it also can help us to see whether the position of the tube is related to the cricoid cartilage, which is at the level of vocal cord. So this is rather shallow. This is rather good. Yeah. So come to case number two. A post-op child PDA ligation noted to have post-extubation stridor. What is the possible cause? So that leading to the stridor. So always in our mind is that there's possibility of vocal cord palsy. So when you do a vocal cord ultrasound, this is what you're going to see, right? And in this situation, if you compare to the normal movement and this abnormal movement, what can you observe, right? So this side have left vocal cord palsy. Yeah, you could see here is moving. This doesn't move very much. Case number three. Okay, if you are on call on a busy night, okay, so there are three same patients come to you at night with this similar chest X-ray, all come in with respiratory distress, and the registrar asking you which are the patient that I should put in the chest drain. Okay, right. So that is the question, right? So now let's look at the basic again, the pulmonary edema. Pulmonary edema, basically, when you talk about pulmonary edema, it's about water in the lung. Okay, so this is a chest X-ray of the water in the lung. So in the pulmonary edema. So this is a normal chest X-ray, mild pulmonary edema chest X-ray, moderate and severe pulmonary edema. So we talk about pulmonary edema, it's basically water in the lung. So if you can imagine with me, right, in a normal situation, we don't have much water in the lung. So in a mild pulmonary edema, you have some raindrops, okay, some water in the lung, and there's moderate amount of pulmonary edema. You got moderate raindrop, and if it is a very bad pulmonary edema, is a raining cats and dog. Similarly, this is a lung ultrasound finding, okay, in terms of pulmonary edema. No? So what this is a line, what we call a B line, is quite similar like a raindrop. Huh? So you have some B line, this is mild pulmonary edema, more B line, like more raindrop, okay, moderate pulmonary edema, and this is a confirmed B line with significant pulmonary edema. Right. in terms of pulmonary infiltration, I mean the consolidation part, okay? The pulmonary inflammation, it can be acute bronchiolitis, pneumonia, COVID, or ARDS. All these can give pulmonary inflammation. The inflammation pattern is from the X-ray is like this, okay? So if you look at the pathology pattern, so mild patch, pneumonia, moderate patch, and whole lung patch up. So similarly, you're going to see in the ultrasound finding, small patch, moderate patch, and a huge large patch. So this is a corresponding lung ultrasound finding. So now back to this patient. So before we put in a chest drain, so now you have gone through all the course in the morning. You can use point of care ultrasound to assist you. So now this is the X-ray for this. Uh, 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 this is the ultrasound for this chest X-ray. Yep. So you could see that this patient will not need a, a chest drain, but what he need is that from respiratory support, like NIV or even intubation, to assist to expand the lung because this patient have collapse consolidation over the right lung with some air bronchogram and even the transverse fissure is seen. For these patients, okay, you can when you do a lung ultrasound, you see that oh yes, definitely there is significant empyema with some fibrin there and a lung collapse. So this patient need to put in a chest drain. For this patient, okay, don't touch, all right? So you could see that, there is a multicystic and they have some solid component. Okay, this child has some growth in the lung. Don't put in the chest drain, Right, this is basically a teratoma over the right lung. So this one can so from in terms of point of care ultrasound, it can help you to make some good clinical decisions. Okay, in a situation like this, whereby you're not sure which patient that require a chest drain, which patient require an NIV, which patient that require to urgent referral to the surgeon. Now, case number 4, right? So you have this 4-month-old child, Down syndrome, and recurrent pneumonia, admitted for respiratory distress. So the registrar had previously on call with you, had put in a chest drain, right? So now he's very confidently and said, bring the chest X-ray to you, say that I want to do a, a chest drain because this child have pneumothorax. Okay, so you could see that there's air collection here. Right? So now this is how pneumothorax can be seen in the point of care ultrasound. You don't have sliding, okay, right? And then this is a suggestive of pneumothorax. So sometimes when you're lucky, you can see the lung point, whereby where the normal lung meet the uh, air-filled pleura. So this is what we call a lung point. So in this particular patient, we expect to see the pneumothorax changes as we had shown you earlier, but it is not. When you did the ultrasound here, you put a probe here and put the other side, you could clearly see that there is some pleural sliding, and you can see that there is some B line here. So this is patient do not have a pneumothorax. Okay, so thankfully you didn't put in a chest drain. Okay, and this patient actually have a huge bulle. Okay, a huge bulle over the left side that mimic a pneumothorax. Now, case number 5, okay, another child, 7-month-old baby, complex cyanotic heart disease, who undergo a BT shunt 1 month ago, presented with tachypnea and grunting. So this is the X-ray. So now the worry is, whether this child have developed pulmonary congestion or not, okay? Whether it's over shunting because of the BT shunt that leading to the lung to fill out with fluid or not. So the question to you is that, should I put in the Lasix? Should I give the patient furosemide to dry out the child to improve condition? So from this X-ray, beside pulmonary edema changes, what else can you elude? So sometimes we might miss things from the X-ray, but if you look at it X-ray carefully, right, you could see that a small, fluid collection here from the chest X-ray. So basically, this patient have effusion, which is sometimes you can miss from the chest X-ray. So this is the ultrasound finding, okay, of the patient. There is a significant collection over the left lung, and you could see that there's some snowstorm appearance over that side. Okay, so go back to the history. Shall have a BT shunt, left thoracotomy done. So our differential diagnosis is this patient might have some chylothorax. So a drain was put in, so definitely the child have a chylothorax, and after the drain, the patient improved. Right, so the child do not require a furosemide or Lasix. Okay, so now it's the final case. This is a child with severe pneumonia. All right, so this show you how lung ultrasound can be used in the recruitment. So it's a very bad child with a very bad lung that require a high frequency. Now we try to use the point of care ultrasound to guide us in terms of lung recruitment. So this is a lung ultrasound finding, okay, that we have seen here. So what we did is this child is on prone position. We put a probe here posteriorly in the center of the spine. Okay, so this is the center of the spine. You could see part of the right and the left lung. So this is, sorry, this is the left lung, this is the right lung, and then in the middle, this is the spine. Okay, so this is a lung finding which suggests a significant consolidation. Okay, as you can see this chart on high frequency, you can see that there's a dynamic air bronchoalveoli which is shaking like a high frequency. We started off with a mean airway pressure of 18 with high frequency. Okay, so now we push up the mean airway pressure to about 26. Within 3 minutes, you can observe there's a significant changes already from the large consolidation area to a small consolidation area. Okay, and at the 10 minutes time, the consolidation area much disappear. 30 minutes, minimum consolidation. So this is within 0 minute to 60 minutes. As you could see that the consolidated lung, okay, can become a relatively well-aerated lung. Now you could start to see some A line already, which suggests that the lung are starting to recruited already. So with the assistance of point of care ultrasound, it can tell us that the lung is fully recruited. And now is when the saturation improve, you can slowly bring down the pressure to a steady manner. Okay, then they can let you able to go back to sleep more nicely, more calmly, without much more worry. Yeah, by direct observation, the lung is recruited. And at the same time, it help you to subsequently bring down the pressure in order to put the patient on a safer pressure. I hope that you enjoy the case discussion. Thank you very much.